Welcome everyone to our meeting tonight, Fixing How We Pay for Healthcare now that we've tried everything else. My name is Judy Barton and I'm with Healthcare for All Minnesota. Welcome, and this webinar will be hosted by Ann Jones of Healthcare for All Minnesota and Dave Dvorak, Dr. Dave Dvorak, and also PNHP Minnesota. If you guys have any questions, Ann, can you move to the next slide for me? Thank you. Please use the chat down at the bottom. I just want to go over a few features for this Zoom meeting. First off, when we get to the Q&A portion, the only way we will know if you have a question is if you use the raise hand feature. If you use your hand in the screen, we will not see you because there's too many people on. So please use the raise hand feature. It should be in your toolbar at the bottom, and there will be a reaction. And then right there, it says raise hand. If you want to change your view, I cannot control your views in the meeting format. If you want to change your view, that's usually at the top right of the screen. You'll see something that says view, and there'll be multiple options there. Additionally, we have it so that no one is able to unmute themselves during the meeting. Only I am able to unmute you. So when you raise your hand, I will call on you and you will see a little pop-up on your screen that says the host would like you to unmute. And then you can click that little blue button that says unmute, and then you can ask your question. If you have other questions or technical difficulties, please ask those in the chat function or chat feature. And we are recording this meeting as well. With that, I'm going to hand it over to Ann.
Thank you, Judy. Thanks everyone for joining us this evening. We're back to spring today, so I appreciate you spending some time with us. A couple of notes before I start. I realize these slides are very busy. Please don't think you have to remember everything or take notes unless you want to. We'll send the slides out, so you'll have everything that we're going to talk about this evening. And then please write down and save your questions for the Q&A part of the agenda, just in case I cover some of it while I'm talking. I'm giving you my contact information at the end, and you can also call me with questions. We are joined this evening by Dr. Dave Dvorak, who has graciously agreed to spend a little bit of time with us this evening. I did benchmark a few slides from Dr. Dvorak's presentation that he gives often, where he says, well, now that we've tried everything else, how about we move to the real solution for fixing how we pay for healthcare in this country. So this evening, we're going to just introduce ourselves, do the about 40 minutes of content, and then we will have time for questions. Dr. Dvorak can stay with us till about 7 p.m. I hope that I think you'll find this program worthwhile. And my name is Ann Jones. I've spent almost 50 years in nursing. I've done a lot of clinical patient care. I've done intensive care, nursing leadership. I'm retired now. I spent most of my time in acute care hospitals in the metro. I've had a long-standing interest in health policy and financing healthcare. I got a master's degree at St. Mary's University in Health and Human Services Administration. I was a flight nurse for the Air Force Reserve for 23 years. And I decided to spend my golden years trying to fix this healthcare payment mess. Dr. Dvorak, could you introduce yourself?
Hello, everybody. Thanks for being here this evening. My name is Dave Dvorak. I'm an emergency medicine physician. I've had the benefit of working both in the private world for a long time with Fairview, and more recently, over the last 6-7 years, I've worked at the Minneapolis VA hospital. I also work at the North Point Community Clinic in North Minneapolis. So I've seen healthcare from a number of different perspectives. I also have a master's of public health from the University of Minnesota, which kind of sparked my interest in healthcare reform and healthcare justice. So thank you, Ann, for having me join you tonight.
And well, we thank you. This talk tonight is going to cover some basics on cost, quality, and access to healthcare in the U.S. and some positive features and benefits of the current bills that have been introduced both at the state and federal levels to move us towards single payer financing. We will explain what the difference is between incremental change and real progress toward a solution. I want to clarify a phrase that you have probably heard already many times, the so-called public option health insurance proposals, so that you can have a response when somebody says, well, couldn't we just, we'll talk about paying for a single payer system, both a Medicare for all and a state-based plan, and then I'll end up with references and resources for you, and also some announcements. So most of us have had some experience in advocating for progressive change in this highly polarized political environment, but this issue can be very contentious. Opponents of change have been quite effective at spreading misinformation and fear of change. I remember a marketing person many years ago saying, the confused mind says no. So we will do ourselves and this movement a huge favor if we can be as well informed about this issue as possible and as clear in how we communicate information to reduce that fear of change and kind of get past the ideological barriers to change. Here's some very basic concepts and things to remember about our current system that I want you to take away from this presentation. We vastly overpay for healthcare in the US, not because we get better care, but because of the waste and inefficiencies in our multi-payer system. We're not getting our money's worth in cost, quality, and access to healthcare, and we leave millions of people out. No matter what you hear from opponents of a national health plan, we do not need to come up with a lot of new money to fix this. We actually know the answer, and the solution is fairly simple. The question is not how, but what is stopping us, and continuing to tinker around the margins is not working. And I would argue further that is preventing us from getting to a real solution. So just a few facts about cost, quality, and access to healthcare under our current multi-payer system. This is the numbers. These are the numbers you need to know. The way we pay for healthcare in the US costs too much, does too little, and leaves too many people out. Latest numbers are that the healthcare industry consumes almost 20% of GDP. That's 1/5 of a $23 trillion economy, almost 1/5. Yet millions of us are uninsured or underinsured or dependent on public programs or go without. Total health spending in 2019, which are the most recent numbers from CMS, are always a couple of years behind, now tops $4.1 trillion or $12,530 per person. Health spending in Minnesota, according to the Department of Health, was $56.6 billion in 2019 and projected to double in 10 years to $104.2 billion if we do nothing. So this is the trajectory. You can kind of see that total health spending is a much higher portion of the gross domestic product in our country than it is in other high-income countries. We spend 2 to 3 times the amount per person of any other developed country, and our health outcomes are much worse. Most developed countries were in a fairly close range of each other in the mid-20th century, and the difference between us and these other countries is that post-World War II, most of these other countries went in a direction of a national health system of some kind, either publicly funded, publicly insured, or at least highly regulated private insurance, with the government stepping in for the uninsured. This is the picture from Minnesota, a report that just came out in October of 2021 on health spending in 2018 and 2019. You can see that the trajectory just goes straight up. If we do nothing, this is what we're looking at. And I said earlier that we're not getting our money's worth. According to the Commonwealth Fund, which studies healthcare systems and health outcomes in the developed world, in 2014 and again in 2017, we ranked 37th overall in health outcomes. We experienced higher rates of chronic disease, and we ranked last or near last in access, efficiency, and equity. In the most recent report called Mirror Mirror 2021, reflecting poorly on healthcare in the US. We came in dead last compared to 11 other high-income countries. It's really hard to argue that we should keep doing what we're doing and just try harder. The picture is even worse for persons of color under our system. Health outcomes for persons of color are significantly worse than their white counterparts, whether measured in rates of chronic disease, cancer, death, or longevity. And the systems in place to serve many members of communities of color are really stressed financially. Racial disparities due to COVID-19 really showed us our deficiencies. Blacks make up 6% of the population, but this slide is a little bit older, but 21% of confirmed cases of COVID-19 when I did the slide. Higher rates of chronic disease plus jobs that increase risk, higher rates of hospitalization, and also higher rates of disease overall. So racial health disparities really represent a crisis within a crisis in our system. So just a reminder of what really contributes to health. When we're looking at the issues of cost, quality, and access to healthcare, it's important to consider all the factors. And I remember I did a little stint at the health department at the end of my working years in nursing, and I was literally shocked when I saw this slide. This was Dr. Ellinger, was the commissioner of health at that time, a wonderful man. And this shows you that for all that money, all that 4.1 trillion that we're spending contributes only about 10% overall to the health of a population. That's really shocking. And when you look at the things that do matter, social and economic factors such as housing, nutrition, education, income, transportation, and the like really account for the biggest chunk of overall health and well-being. It really suggests that we need to shift some resources from our acute care system to other supports. Health behaviors do have an impact, smoking, alcohol, obesity, and so on. But there's an argument to be made that if we would distribute resources differently, we might be able to influence some of these factors. And then primary care physicians, pediatricians, and mental health providers would probably agree that our mix of spending on acute care versus primary care is flawed. So another look at racial health disparities. And then this is some of the really basic things to know about our current system, and I'll just really highlight a couple of them. The one big thing to remember and understand is that 34 cents of every healthcare dollar in the US is consumed and spent on non-healthcare activities, the administrative costs of our multi-payer system. And that 2/3 of health spending is already taxpayer funded through all the various programs we need to have to fill the gaps in between the private insurance system and coverage. Plus, taxpayers subsidize our employer-sponsored insurance model. So and bottom line is we believe that healthcare is a public good and not a commodity. How do we currently pay for healthcare? I've got a picture here. It's a very busy slide, but just for you to have, and you'll get the slides, that it's just for a flavor of how many different pieces of a system are required to cover it, even as inadequately as we do. This is the piecemeal way that we cover people in this country. Many of these are public programs to fill the gaps in the employment-based model. Dr. Dvorak mentioned North Point. That's one of the federally qualified healthcare centers. There are, I think, 18 in Minnesota. I'm not quite lost count. People don't understand that there are 1,100 federally qualified health centers around the country, and they care for literally millions of people, often uninsured, Medicaid, and undocumented persons. That's just one of the pieces. And the rest is a list of all the many ways we cover health. You can see why this is impossibly administratively burdensome. So this is what is called our multi-payer system, and it's not a system at all. It's a patchwork, only with a lot of holes in it. This graph shows how people are covered in Minnesota, and I'm gonna just let you have that for information. And I wanna go to Dr. Dvorak, because it isn't as though we haven't already tried to cut costs.
Thanks for that overview, Ann. I think you've laid out the problem with our healthcare system well. namely the fragmentation of this system or the non-system, which has led to mind-boggling complexity and staggering costs. Again, as Ann said, the problem isn't that we're not spending enough money on healthcare. We're spending far more than any of our other Western democracies. The question is, where is that healthcare spending going? And it continues to increase year after year. Will increase at a well greater rate than the rate of inflation, even the current inflation. And the way we've gone about trying to rein in this inexorable growth in cost has been essentially to nibble around at the edges. And I don't know if you can bring that slide is auto advancing. If you can bring it back.
Oh, I did move it, but.
Can you bring it back, please? Sorry. Okay. So what you see on this slide is a number of different types of cost containment strategies that health economists, and basically people with MBAs and policy people have tried to do to contain this cost growth. You'll recognize some of these, maybe personally. Most of us are in some form of an HMO or PPO, which kind of got their start in the 80s, trying to contain cost by basically bringing providers and hospitals under one payer umbrella. But that ultimately did not contain costs like we hoped. One of the more recent buzzwords is accountable care organizations, which was a Medicare mechanism, which is they're basically super HMOs, which again have failed to contain costs in any significant way and not improved quality of care. Okay, we'll go to that next slide. And I kind of made this slide of an alphabet soup because a lot of these cost containment strategies are often given these acronyms: ACOs, HSAs, high deductible health plans, which most of us have, by the way, now, where it's not uncommon to have, you think you have an insurance coverage, but it turns out you have a $5,000 or $8,000 or $10,000 deductible for yourself or your family policy, which means your insurance doesn't even kick in until you've laid out $10,000 of your own money. So for a lot of people, it's essentially like being uninsured because they make many families, many low middle income families, they don't have $10,000 sitting around, and they make their decisions of whether to access healthcare by whether they can afford it rather than whether they need it. So we see there's a lot of studies that show on the order of like 30% of Americans in any given year report that they forego or delay needed care because of inability to afford it, even despite having an insurance policy. So that's obviously not a solution. It might decrease utilization, and that might be a good thing for private insurance companies because then they're less on the hook to pay claims. But it also leads obviously to poor outcomes in terms of people not being able to access care when they need to. So yeah, EHR were the electronic health records, which have kind of turned out to be more electronic billing tools than having great utility for patient care. I mean, they're kind of a double-edged sword, but they can be real headaches, and almost all providers are dealing with an electronic health record now. It's just the way that it is. So if you go to see your doctor, good chance they're typing on their laptop and staring at their screen rather than making contact with you, the patient, because of these electronic health records, which again have not contained cost, and in some cases have actually led to higher bills, and because again it is a billing mechanism at the end of the day. And then we've got these were supposed to be cost containment strategies like these Medicare pay for performance measures, and a lot of these have no clinical relevance and end up just being really frustrating for physicians and don't lead to better care. It just leads to more bureaucracy and more headaches. This slide, can we go back to that one, Ann? I think these are auto advancing. If you happen to hop on MNsure, and maybe you get your insurance through MNsure. When I did this and put in my demographics to see what plans I qualify for, what it kicks out is dozens of plans. And the most recent I did this year, I think there were 62 different private insurance plans that I could sign up for. And you'd have to choose from one of those. And so what we see is this mind-blowing complexity to all these plans. And the insurance companies, by the way, are they're very savvy in how they market themselves, because if you look at the billboards for the advertising for medical insurance, they'll say, we have a plan that fits you. Okay, so they make you believe, they know that Americans like choice as consumers. They like to have choice. So what we're given is literally, there's hundreds of different plans in Minnesota, different healthcare plans that, so we think we have this choice, like, oh, who doesn't want choice? But it's really a bait and switch, because what's really ironic is when you choose a plan, you find that you're in a narrow network of providers. More and more health insurance companies are trying to save costs by limiting your network of providers. So you have a plan that's different than last year's plan. You might find that the doctor you've had for many years, or the cardiologist or the family medicine doctor, they're not in your new plan. So what we've got is a choice of plans simultaneously constraining our choice of providers. And I think if you ask most Americans, where do you really want your choice? They want a choice in their doctor, in the hospital they go to when they're sick. But that's the exact inverse of what's happening in this current climate. And I'll just say that all of these private insurance plans, essentially, they're all business. All these insurance companies, first of all, at the end of the day, are businesses, and the primary goal of any business is to be profitable. And then think about the fact that all of these different insurance plans are essentially duplicating each other's service. So basically, they're all private insurance plans that are duplicating each other, taking our premiums every month and spending a big chunk of those premiums on things that have nothing to do with healthcare, things like advertising, their marketing forces, their underwriters, highly paid executives. The biggest insurers nationally are for-profit companies. So billions, literally billions of what they take in premiums leave the system and go into the pockets of investors. United Healthcare last year, their profits were over $20 billion that left the system and went to investors. So when Ann talks about how over 30% of our healthcare spending is not going towards healthcare, well, let's follow the dollars and see where they're going. And unfortunately, a far too great chunk of our healthcare spending is hemorrhaging completely out of the healthcare system. Next slide, please. So as private insurance has not solved the problem despite all these plans. We think that should be covering our healthcare needs and ensuring our population. But even despite the Affordable Care Act, which got a lot more people coverage, many of these people were just basically were covered by private insurance plans. So basically the Affordable Care Act was a big boon for the private insurance industry, because 30 million more Americans got insurance, but many of them got private insurance that was largely subsidized by the federal government. So it's basically federal dollars that are being channeled into the private insurance companies. So we've had some longstanding public programs to try to get people covered who have been left out of the private insurance system. since the beginning of private insurance, the model has always been to be profitable, as I said. And one of the ways to be profitable is to avoid sick patients. So prior to the ACA, we all know that private insurance companies denied coverage to people with pre-existing conditions or charged them premiums 2 or 3 times higher, which were essentially out of reach. So they have always tried to avoid the sickest and the most expensive patients. The Affordable Care Act has made that largely illegal, so you cannot be denied based upon your pre-existing conditions. But private insurance companies still have mechanisms to try to cherry pick the youngest and the healthiest patients who are most profitable. So so back in 1965, we can go back there again, Medicare and Medicaid came around in the Lyndon Johnson administration. Medicare, of course, to cover our elderly Americans or Americans over the age of 65. Who again couldn't afford insurance by virtue of their age and medical histories, and then Medicaid to cover the poor. We've got other things, other patchworks to try to fill these gaps. The state children's health insurance program. Of course, we've got the VA, where I mentioned I work, that covers our veterans. The Indian Health Service to cover health needs of Native Americans. Federally qualified health clinics, which basically treat a lot of publicly financed patients through Medicaid or uninsured patients who are self-paid and end up paying sliding scale. And then county hospitals. This is where people who are uninsured still seek their care. They go to, again, community health clinics or emergency departments of county hospitals. Yeah, even FEMA has gotten involved in helping cover some of the gaps in terms of emergency situations. So a lot of, again, just trying to plug these gaping holes in our healthcare system through, again, a very complicated patchwork of public programs. Next slide, please. So as an example, I like this example. I don't like it, but it's a very telling example of how complicated our system is. This is Duke University Medical Center, which has 957 beds for patients. Their billing department employs 1,600 billing clerks to deal with the complexities that are baked into our multi-payer system. When each of those patients in those 957 beds have different insurance coverages, different formularies, different coverages for procedures, you need a whole lot of billing clerks, almost 2 billing clerks per bed, just to deal with the complexities of the hospital trying to get paid from all of these different payers. So this, again, when we think about where all that extra money is going, that wasted money in our system, that's not going towards healthcare. You look at, all of the billing clerks at just one hospital. And then here's another way of looking at, our bloated bureaucracy of a healthcare system. This looks at about 40 years of growth. The little yellow sliver at the bottom of that chart shows the growth in the number of physicians over the course of 40 years. And then that big kind of teal, light blue colored mountain that's still growing is the growth in the number of managers and administrators in the healthcare system. So these are all the middlemen, middle people, administrators that are just that are needed to contend with this ever-growing complexity of our system. Again, most of these people are involved in the payment mechanism, in negotiations that go on, and the payers and on the insurance side, and also on the provider side. So we're becoming very top heavy in terms of administrative bloat. Next slide, please.
And to Dr. Dvorak's point about insurance companies as a business, this is our very own United Health Group.
So yeah, and not to pick on United Health Group. Sure, let's pick
except they just
because you're gonna these guys are one of the giants, and they're based right here. And if you drive by their, they're very palatial. Their palatial corporate buildings out in where is that? Is that Eden Prairie or
Plymouth, I think.
Plymouth? Yeah.
Maybe. Yeah.
Yeah, even from the outside, it looks like quite an empire. But look at what the executives pulled down. David Wickman, 2018, $52 million. He realized $52 million in stock options and bonuses as the head of this company. $52 million. And I want you to realize that David Wickman does not treat patients. He has no role in patient care. He runs a business, a profit-driven business, and he's handsomely rewarded for this. Know that United Health Group is for profit, and it is not. There's a division called United Healthcare. Realize it's not involved in health care for the most part. It's an insurance company that's a middleman. And then it's not just the top guy, but you take the top 6 executives with United Health Group, and you add up their salaries, you come up to over $162 million in 2019 alone. And then you look at the Medtronic, which is a medical device company, and you see the exorbitant salaries. Again, there's a lot of profit taking in the system as it stands, without ability to negotiate fair prices for drugs, medical devices, medical supplies. You end up with a lot of opportunity for profit taking, and that's what happens. And again, realize that these folks are not. I've never seen them in the hospital, in the ER, in the middle of the night. They're running businesses, and they have no role in healthcare.
What's really shocking new information is that I think first quarter of this year, last quarter of last year, 70% of the profits that United Health Group raked in were public programs. These are taxpayer funded programs. So we're literally pouring public money into this massive, black hole for money. Why in the world wouldn't we just cut out the middleman?
Right. Which, in terms of, medical, in terms of public programs, Medicare, as it was first adopted, was a single payer system for our Americans over the age of 65. It was initially a single payer system, but now through Medicare Advantage, all private insurance companies see this as prime pickings for a lot of profit. And a lot of Medicare Advantage plans are through United Health. And as our Medicaid, the private insurers are actually, they see the Medicaid program as a great opportunity to make more profits as well. So, and as you mentioned, and most of our healthcare spending comes from government sources, but a lot of that government money or public money is channeled through these private insurance companies that take off their share and continue to be insanely profitable year after year.
Dr. Dvorak, thank you so much. We have to let you go so that you're not late for your next commitment.
Okay, well, thank you for having me.
We hope to invite you back, and look forward to hearing from you again.
I'd be glad to come back.
You will, okay.
All right, thanks, Ann. All right, thank you, everybody.
Bye-bye. So what's the fix? What are we fighting for? We thought we would try to make this really clear for those of us who we're all going to be, we hope, talking to friends, family, neighbors, coworkers, voters, since this is an election year. The good news is that some really great legislation is already written. Current proposals put us on a dual track toward a national health plan, improved and expanded Medicare for all. Many people are familiar with the Canadian system, which got its start in one province and then expanded across the country. And so similarly, a number of states in the US are working on state-based health plans, although we all agree that the most efficient system would ultimately be a national health plan. Here in Minnesota, we have the Minnesota Health Plan, written by Senator John Marty, which was reintroduced in 2021 in the House and in the Senate. The sponsor for the House bill is Representative Cedric Frazier. No hearings on these bills have been held in some time in the state of Minnesota due to the mix of political parties in the state legislature. The new Medicare for All Act of 2021, which was reintroduced in March of this year by Pramila Jayapal, Representative Jayapal, on the House side is H.R. 1976. A new Senate version was just reintroduced today, May 12th, 2022. The new bill resolves some of the major policy differences between the House and Senate versions that health policy experts have been worried about, such as adding global budgeting for institutional providers. So this is really good news. I don't yet have the bill number if it has changed since it's been reintroduced, but I'll find that out and get it on the slide. The chief author of that bill, of course, is Senator Sanders. So they had a hearing today for the bill to be reintroduced. I believe there have been 1 or 2 hearings on Senator Jayapal's bill in the last year and a half or so, and no votes have been taken. So what's in the bill? What are in these bills? We throw around the words Minnesota Health Plan or state-based health plan a lot, but it's kind of key to understand what we're really talking about. And I really encourage reading the bill. It's actually pretty interesting to read. And also, Senator Marty has written a book to explain this proposal. But the Minnesota Health Plan would cover all residents of Minnesota. Universal coverage is the basic promise for all medically necessary care, including dental care and long-term care. Patients can choose their providers. No networks are required, which is really the choice people want if you think about it. Costs would be reduced by cutting administrative waste, not by denying care. Premiums will be based on ability to pay. The federal plan is proposing no premiums to be fully taxpayer funded. In the state of Minnesota, we don't have all the funding streams for that to work, so there would be premiums based on ability to pay, but it would set up a dedicated health fund so that it couldn't be robbed for other expenses. There could be a focus on preventive care when you have a well-organized system, and a process for ensuring sufficient numbers of providers. Goals would be to continue Minnesota's leadership in medical education, research, and technology, of which we are very proud. Provide adequate and timely payments to providers and global budgets, especially for institutional providers, which would we need to remember to emphasize that this would stabilize rural hospitals, which are often in financial stress from lack of reimbursement or just volume, and also stabilize underserved and underfunded urban hospitals. Would use a simple funding and payment system and provide for a just transition for workers, and include provisions for workforce development statewide. You may have heard about problems with providing obstetrical care outstate, mental health, and dental care. Those are 3 areas that are lacking in providers outstate. So, as Senator Marty emphasizes, these principles would be specified in law and used to govern the system, and would be legally binding on the board of the Minnesota Health Plan. If you haven't already read the book, Senator Marty wrote the bill and wrote the book. And this book presents a rationale for a unified, universal state-based system, covers the principles of the proposal, policy behind the change, specific provisions, all the other pieces of the bill that I talked about, and includes considerations for financing the new system and the economics of the Minnesota Health Fund, and talked a little bit about the politics of getting this change done. So if you haven't, I have copies of the book if people want it, and also it's available through the resources tab on our website and the MinnesotaHealthPlan.org website as well, Senator Martin's website, or the website for this bill. So the federal plan, again, reintroduced as HR 1976 in March of this year, and today as the Senate version. These are really good bills. These have been in progress for many years and are the result of the work of numerous health policy experts, advocacy organizations, and stakeholders. This bill includes a heavy emphasis on health equity and accountability for underserved populations, and including rural areas and lower income urban areas. The key provisions of the bill are universal coverage. Again, the central promise of both of these bills, no exclusions or exceptions. And if you remember, the ACA made a compromise early on when the bill came under fire, of course, from opponents about including undocumented persons. Make it clear when you're talking to people that all means all. This time around, we are not going to be excluding anybody. A comprehensive benefit set, including long-term care and dental care and so on. Freedom of choice, again, doctors, other providers, hospitals, and other facilities. It includes the full range of reproductive services and removes the Hyde Amendment. I will mention, and you've probably heard a lot about this in the news just recently, within the last 2 weeks, that the Medicare for All Act and the Minnesota Health Plan as well provide coverage, as in the payment for reproductive services. However, legally being able to access full reproductive services would require passing the Women's Health Protection Act. Which has passed in the House and was received a vote yesterday in the Senate, and of course garnered 48 out of 100 votes, and of course nowhere near the 60 vote threshold required to meet the 60 votes. So that needs a lot of work, and that's something we might want to be advocates for as well as we work on getting this bill passed. This bill would remove the financial barriers to care. The federal bill proposes to cover everyone using taxpayer funds and would require no co-pays, deductibles, or co-insurance payments. So no out-of-pocket expenses. Would provide for a single standard of care for everyone. It specifically prohibits a two-tiered system. So if people ask you, well, you know, can people buy extra insurance if they need to or want to? There should be no need with the comprehensive benefit set, unless there's something, maybe cosmetic surgery not covered. But health equity means no two-tiered system or people getting in to the front of the line. We mean equitable for all. So also provides for global budgeting for hospitals and other institutional providers and physician practices. Bulk purchasing and negotiating prices for drugs, devices, and fees, which of course is where a lot of, in addition to the administrative savings of a single payer system, this would allow us to start negotiating prices for some of the really expensive parts of our system, and that further cost savings can be realized down the road or over time. There is a requirement in the bill for planning for natural disasters, epidemics, and pandemics. Targeted funding for rural hospitals and underserved populations, big emphasis on equity. A transition plan that protects workers, provisions for safe staffing standards and workforce planning, so that we have enough people in the pipeline to provide all the services we want to provide. And then the Veterans Administration and Indian Health System would be preserved as is. If you could ask that question. So, with everything that's possible, if we would go to a system as described in these bills, those of us working on change believe strongly that we're at the point of accepting, we're past the point of accepting any more band-aids. on the hemorrhage of money and the harm being done by our multi-payer system. You will hear lots of arguments for incremental change over doing something all at once. And my response would be that people have been trying to fix how we pay for healthcare in this country for over 100 years. It's really past time for real reform. I would also argue that incremental change is tempting, but most often is not the answer. We risk wasting time, money, and political capital working for small changes that will not solve the underlying problems of administrative waste, high prices, and lack of coverage. Meanwhile, real people are dying or going broke. So let's work for what we really want and what will actually fix the problems of cost, quality, and access to healthcare in Minnesota and in the country. You know, I would also point out that the disruption entrenched in our current system really makes the argument of it would be too difficult to change now kind of a silly argument. Millions of Americans lose insurance every year when they change jobs, lose a job, get sick, or this, of course, during this most recent COVID-19 pandemic. And also, lower income persons often cycle in and out of eligibility for public programs, which really works against continuity of care and management of chronic conditions. So, what are some examples of incremental change? This is just kind of a short list of a few of the initiatives that have been proposed or introduced as legislation. And they get some support from certain constituencies, but really fail to address the underlying problems of the administrative costs of our multi-payer system and the high cost of services due to lack of any price controls. So again, this year, the legislature is poised to pass a reinsurance bill pushed by the commercial insurance industries under threat of raising premiums if they don't get what amounts to a taxpayer subsidy for coverage that they are supposed to be providing already. This year's bill calls for $1.1 billion over 5 years with no strings attached that I'm aware of, and little or no oversight for where that money is going. So again, some of the suggestions for incremental change have been, you will hear a lot about bringing down drug prices. That's a very popular one and very non-controversial, or mostly non-controversial, I should say. You'll find people voting against it. Fixing surprise billing is very popular with lawmakers, although a bill for that was proposed both at the state and federal levels and got voted down. This is for when your specialty doctor is out of network and you don't know it when you go into the ER, or your anesthesiologist maybe isn't in network if you need to have surgery. The public option that I'll cover more in a slide or two for people who can't afford private insurance. Premium subsidies for plans through the insurance exchanges. That's all. We are spending a lot of money subsidizing the insurance industry under the current system, and then posting prices or fees. That's really difficult because there are no standard fees and so on. These are just a few. One relatively recent example of an incremental change in Minnesota that passed during the last biennium to provide short-term emergency assistance for insulin-dependent diabetics to buy a life-saving drug at a cost they can afford was the Alex Smith Emergency Insulin Supply Act. I do not minimize the importance of this bill by any means. This was the result of an incredible amount of effective lobbying and advocacy and the efforts of very dedicated legislators. But as Senator Marty points out, it took 2 years and 9 months to pass. This is time spent on a measure for one drug for one disease, and it doesn't really help people who can't afford their medications for numerous other diseases, which can be very expensive. And a portion of the bill sunsets in 2024. I guess what I'm trying to say is we really don't have time to do this one by one. So people are suffering and even dying for lack of the health care they need while going bankrupt trying to pay for it. So I promised I'd talk a little bit about the public option, and we need to understand this because it comes up so often, and because a version of a public option was introduced in the legislature in 2021. I think it might be in the omnibus bill that's still being discussed, at least on the House side. And there are several proposals over the past that have been made at the federal level over the past few years. And I think one of the basic things to understand is that it's not the public option, it's several proposals. It's not just one. So even people who are kind of with us on getting to universal coverage kind of think that maybe there's a step in the middle or several steps. And some of these bills are proposed by people who are genuinely concerned about getting more people covered and would like to get to universal coverage, but just can't get there with actually eliminating private health insurance, which, as you know, we need to be saving that money. This phrase first came up during the run-up to the Affordable Care Act and was quickly dropped because the commercial health insurance industry objected. So again, it's important to understand that there's no one public option health insurance proposal. There are at least 7 bills written at the federal level and some version, in some version or another. It's a catch-all phrase because proposals vary. They're sometimes called Medicare Extra, proposed by the Center for American Progress, a Medicare buy-in, a state public option is based on Medicaid, a Medicare buy-in for older adults that could be considered a public option. Some policymakers argue that a public option would eventually become so popular that we will naturally transition to a single payer system. That is very unlikely, and Medicare for some is really not the answer. Private health insurance companies keep their premiums artificially low or hide the real cost of premiums by shifting costs to taxpayers and public programs and by increasing the out-of-pocket costs to policyholders. So this would just be another version of that. I took a close look at one of the proposals recently and learned that the eligibility was very limited, coverage was low, included high out-of-pocket costs in addition to premiums, and enrollees would be exposed to significant financial risk. And finally, the commercial health insurance vehemently opposes any publicly financed insurance for working age people because that's their market and they will likely lobby against it. So those are the political realities. The way it works is that health insurance companies and employers would likely cherry pick healthier beneficiaries, get rid of thicker and costlier beneficiaries, which is called lemon dropping, shifting those beneficiaries to the public option or other public programs. The public option would then become so-called more expensive per person and it will fail. The pool of beneficiaries just isn't large enough. People then will conclude that that government thing didn't work and the public option does nothing about administrative costs. In fact, it likely increases them. Some public option proposals even involve contracting with private insurance. And as I said, the commercial insurance industry opposes and will lobby against it. So those are all kind of the downward spiral of what would likely happen if we introduce yet another insurance option to the already cluttered multi-payer mess. So all that said, and if you're like me, you want the big fix, but it's not likely right away. So are there some steps that we could take along the way that would be real progress and not detours or distractions? Are there some bridges that we could build toward our desired solution? And the answer is yes. There are some policy steps that would make sense to get done sooner rather than later. These would be interim steps toward a real fix. And how do we know the difference between incrementalism and progress? When taking a look at a particular proposal or a bill, ask yourself, does this meet the test of being good healthcare financing policy, even if somewhat short of the change we really want in any of these areas? Specifically, does it meet the test of lowering or eliminating administrative costs? Does it reduce or eliminate the influence of the private health insurance industry? Would it help build the administrative structure we need for a state-based or a national health plan? Would it meaningfully increase the number of people covered? Does it actually make healthcare more affordable for individuals and families? Does it remove the barrier of cost? Does it offer more choice of providers or facilities? Does the proposal assure comprehensive coverage? And does it include any cost containment authorities or provisions? So these are examples of some of the steps we could take towards a single payer, state-based or a national health plan. A drug pricing board or commission, as proposed by the Attorney General's Drug Pricing Commission a year ago, would be part of a structure we would need for a future single payer or Minnesota health plan or Medicare for all national health plan. So, or possibly removing the eligibility requirements for Minnesota Care. Minnesota Care is actually really good insurance and would not leave people subject to a lot of out-of-pocket costs. So that could cover more people. It would likely, it would reduce taxpayer subsidies needed for plans purchased on the exchange, but might require subsidies for people to use this, this kind of coverage. And it would also reduce the influence of commercial insurance industry if we got the commercial insurance industry out of our public programs and required them to be publicly administered. Because Minnesota Care and medical assistance right now are being administered by the private insurance industry in Minnesota. We could expand Medicare benefits in the American Families Plan. Unfortunately, that doesn't look like it's going to get a vote anytime soon. It was the second part of the big Build Back Better bill that got separated from the infrastructure bill. And then Senator Marty's proposal of for primary care case management and direct contracting would remove private insurance intermediaries or public programs and reduce administrative costs. That, of course, has been introduced in the state Senate, but has never been voted on. And there may be other interim policy steps that could be considered, but now you know some of the questions to ask yourself when evaluating these policies. So anyway, sounds great, but how do we pay for it? Even when you're talking to people who are with you on the issue, this will come up either as a genuine interest or kind of in getting more information, or sometimes as a gotcha question. And it sometimes takes us by surprise, because even though we're learning and we're studying and we're listening to talks and so on and we're reading, it's a good idea to have an answer kind of formulated because of all of the misinformation and disinformation and drama and polarization and ideological opposition built up over the years around this issue. So as you become more active in working on reform, it's helpful, I think, to practice an answer. And for some numbers, if you remember when we started this talk, you know that 1/3 of total health spending is consumed by the administrative burden of our multi-payer system. That's about $1.4 trillion out of a $4.1 trillion in total health spending. PNHP co-founders Steffi Wohlhandler and David Himmelstein, along with a number of other economists and health policy experts, have studied healthcare costs in this country, and they estimate that about somewhere between a third and a half of that can be saved that's 450 to 600 billion per year in savings if we shift to a single payer financing system. This is enough money to cover everyone and expand benefits before making any other changes. This is before we begin to negotiate prices and study actual costs to provide services and start to apply standard pricing and fees to drugs, devices, diagnostics, hospitalization, home care facilities, and even before shifting to a global budgeting system for facilities and practice groups, and any of the other strategies in HR 1976 to manage costs. So the answer to that question is there is already enough money to go around if we are willing to reimagine how we organize and pay for healthcare and public health services in this country. Taxpayers, the public, are already funding numerous public programs, as you have learned, to fill the gap in coverage left by the employer-sponsored private insurance model, not even including the subsidies they receive for offering health insurance. So We'll continue to talk about messaging in future presentations, and but you will also run into the strongly held belief that has, I think, been kind of, people have been trained to think that Americans don't want government-run healthcare. And a good response for that is that under a single payer Medicare for all financing system, government is the payer, not the provider. I mean, with the exception of the publicly run, clinics and hospitals that we have, but basically, government is the payer, not the provider. You will still have Health on the door, Alina on the door, Mayo Health System on the door, Stanford, and so on. Those things don't change. It's the funding and the financing that changes. So that's just something to have in your toolkit. We can get into some specific sources of funding later. Some are simple, some are more complex. But for right now, we should just avoid feeling defensive about this question and say there's plenty of money to go around. We're already spending it, and we just need to reallocate and reorganize. How do we know that we can pay for a single payer, a Medicare for all system? Not just by the numbers I talked about, but this proposal has been studied multiple times. And this graph shows, for example, the result of 22 major cost analyses at both the state and federal levels of the impact of total health spending on total health spending of a single payer financing system. All but 2 studies show savings depicted by that blue line. And this presentation you can find on the website for pnhp.org in a presentation on the economic feasibility of single payer healthcare. Wonderful website loaded with information. The notes on that slide in the presentation say that all expected savings are at the 10-year mark. I would also comment that the point of a single payer Medicare for all system is to cover everyone, deliver healthcare, and reduce health disparities. If we save money doing it, that's really a plus. Notably, a new I think it's called working paper, came out in February from the Nonpartisan Congressional Budget Office in February of 2022 on the 6 channels through which a single payer system would affect the economy. You can see by the like the summary statements that they came up with that they're really very focused on the economic benefits and the impact on the labor market, but it's a really interesting slant that they take. So this is not, this is at least the second, maybe even the third time they have issued this report. I'm not sure why members of Congress aren't really using this more to make their case, but it's an interesting paper. It says that, compensation would change because wages would no longer need to include health insurance benefits. It would increase taxable wages. Out-of-pocket costs would go down, administrative costs would go down, productivity would go up, longevity, the only thing they say about health is that longevity would increase, but they tie it to labor productivity. And then they even say long-term care and support services would be covered, so those people would be freed up to be in the workforce. So you can see that this is very focused on labor market and productivity, but it is a really interesting statement that kind of confirms what other studies have shown. So Healthcare for All Minnesota and Physicians for a National Health Plan and the Minnesota Nurses Association has invited a number of organizations to be key allies in building a movement for a state-based health plan. In other words, how are we going to get this done in Minnesota? This is going to take the combined efforts of issues organizations, small business, labor, farmers and rural residents, faith-based groups, healthcare professionals, special interest groups, nonprofits, elected officials, voters, and the general public. We are relying on a lot of organizations and all of us to really spread the word and build this movement, along with and build the political will to push elected officials to debate and pass these bills. And I would just point out finally, this is I guess, probably the last part of my argument, that we have already decided that it works well to do literally hundreds of functions and services that communities and societies need together. None of us could afford to pay for these services separately. I think part of this effort is going to require changing our language and attitudes that have been built up over decades around healthcare as a business, and emphasize that healthcare is a public good that requires a public solution, similar to the things that we already do together, like schools and police and fire and emergency services and even the military and law enforcement. So I think these are I'm kind of trying to give you some tools to have in your toolkit when you're discussing this with other people and saying, you know, why is healthcare any different from some of these other things that we all need as members of a society? Okay, the rest of this is a lot of resources that you've seen before, but we're working to educate, organize, and legislate. But the most important thing you can do as an activist is become as well informed as you possibly can be about cost, quality, and access to healthcare under our current system and proposals for change, so that you feel really confident to have the conversation and advocate for change. So this is list of resources, a list of websites of organizations who are working on this at the national level. This is one of my favorite books about a movement building, Medicare for All, a Citizen's Guide. And then I'll kind of close with, after all these numbers and, you know, rational arguments, I want to say that this is in the end about social justice and everybody in a system where everybody's in and nobody's out. Martin Luther King said in his letter to from the Birmingham jail in April 16th in 1963 that injustice anywhere is a threat to justice everywhere. We are all in this together. I think I'll stop now for questions.
Thank you, Anne. Everyone, you are allowed to turn on your cameras if you want to. I now invite people, if you have questions, to go ahead and use your raise hand feature under your reactions on your toolbar on the bottom. And I would be happy to call on you as you have questions.
Does everybody know where to find their start video? Down on the left. So we set this up as a meeting so that we could kind of interact by having people on the screen. So we invite you to turn on your videos. Yay! Okay, and go ahead, Judy.
Oh, some people are saying that I need to turn your video on, but you should all have the ability to do that, but for some reason, some of you don't. So while I do that, does anyone have a question? Anne, do you have any other comments that you would like?
Well, we have a few announcements, and we do want to talk about a couple of fundraisers that we have coming up. We hope you will be able to join us.
Yes, just a second. I'm letting everyone start their video because
okay,
I did not disable that, but for some reason it's not allowing it. So if you want to start your video, you can. You don't have to. Just FYI. We do have our May fundraiser on next Friday, May 20th, so a week from tomorrow, at Minnehaha Park, Waban picnic area, shelter D, at 5:30 p.m. I think Anne has a little slide that has it up. If you have not purchased tickets and you want to come, you can do that. I will, in a little bit, drop the link into the chat. And
there we go.
You can also get to it from our website. hca-mn.org. It should be right there on the home page for you to click to purchase tickets. It's $25 per adult ticket or $10 for kids 12 and under. That does include a voucher for food from a food carts, a food truck. And then there's also drinks and desserts, and we'll have a raffle and a small silent auction with some cool prizes. So I would love to see everyone there. I'm sure Anne would love to see people there.
If you, we keep putting our social media sites up. If you would go into Facebook, for sure, and I think Instagram, there is a really good, flyer. And if you would be willing to share that with others,
Sure.
So that we can encourage more participation. We have a lot of really fun raffle items, silent auction items. Come planning to think about one of our fabulous silent auction items in our basket.
We do have a question, Anne. Can I stop
Henry?
you for a second?
Yeah.
Henry, would you like to ask your question?
Yes, can you hear me?
Yep.
I'm wondering if Anne could walk us through an example of how global budgeting would actually work. I've heard the term used many times, and people will ask me, well, how, if I'm at an institution, how would that affect my institution? How would they participate? In other words, how would it work? So Anne, could you walk us through that perhaps?
Yeah, great question. The concept is that hospitals need to have a stable funding to pay their staff, buy their supplies, do the maintenance, keep the lights on, and just function. So operational costs would be allocated based on the institution submitting a budget. And when they first get started, they would have to go with a historical cost. And of course, it will be adjusted over time because it's probably too high right now. So I think I've read they would look at the past 3 years of costs and based on their volume in the types of patients they take care of and submit a budget. There's going to be a health fund, probably managed regionally. If it's a national health plan, Minnesota would be managed, at the state level. So the institution would be responsible for preparing a budget and submit their costs for just day-to-day operations. And they would no longer bill for every separate Band-Aid and aspirin and, hip joint. So that's, and they would start with Medicare based, this is what I've read now as a proposal, start with a Medicare cost and plus 10% is an example of how much they would be allowed to get paid. So, and then they would adjust those budgets. I think they're allowed to adjust quarterly, so you don't have to project a year ahead. You can adjust as your volumes and services change over time, fairly flexible. All institutional providers would be under this system. It's pretty well, it's described in the federal bill a little more fully than in the state bill. Does that make sense? Capital expenses are separate. They would have to provide a request for capital, like if you want to build a new wing or add a new service line that you're not accustomed to, or buy a big piece of equipment. Those kinds of things are called capital, and they would be submitted differently, and you would have to demonstrate a need. That's the concept.
That helps, but it actually, it sounds a bit like the old certificate for need system, which, as you probably recall, was incredibly bureaucratic.
Yeah.
And for those, I've argued with people that I think it would be a benefit, particularly for some rural hospitals that have had services denied by their parent because they're too costly. In other words, they don't make a profit. And it would democratize the process of deciding what services would be best offered closer to home in some of the rural hospitals. But I'm a bit concerned about the certificate of need analogy and how that would
Yeah.
turn people off, perhaps.
Yeah, the same thing occurred to me. That was kind of back in the 60s when they were trying to not have every hospital do cardiovascular surgery or every hospital have, you know, an MRI. Well, we've blown right past all that, you know, in later years, but those are capital. So operating expenses, this would be kind of a new system. You know, remember the slide where Dr. Dvorak talked about 1,600 billing clerks? We would not need to account for, and really accounting for these, for costs is completely inaccurate anyway.
Yes.
We would probably be more accurately accounting for our costs if we just accounted for what it costs to run your hospital. And I'm not sure we would have a need for $2 million CEOs anymore either, but that's a whole nother subject, right? Yeah, good question. And I think this is an evolving subject. Any other questions? And if not, I want Jenny to announce a fundraiser for PNHP.
Let's go ahead and let Jen go ahead with her fundraiser, or her, what she was talking about, the PNHP thing. And then if anyone has questions, go ahead and raise your hand and we'll get back to you after.
Okay, and I have just a few announcements at the very end.
Well, thank you so much, Anne, for that great presentation. I'm so glad so many of you were able to join us tonight. And we'll see you all at the fundraiser that is coming up next week, and that is the Hcam Fundraiser. This coming Sunday, the 15th, PNHP Minnesota will be welcoming our newest student interns. We will have 17 students that are currently med students or graduate students at the Public School of Health here in the Twin Cities. Joining us for 7 weeks this summer in an immersive program. They're going to be doing between 100 to over 200 hours of study on single payer and how to become strong advocates in their field as future physicians and wherever they choose to go after the program. So it's a big commitment that we've made to these students this summer, and we're hoping that you will come and join with us to celebrate them this Sunday, the 15th, at East Lake Craft Brewery, and that is in the Midtown Market building on Lake Street. So it's this Sunday. We're joining together at 1 o'clock to welcome them. And if you can't join us, but you really enjoy a good craft brew, that's great. Our fundraiser goes all day until 9 p.m. and anyone who purchases any of their craft brews, whether that's dine-in, takeout, pickup, delivery, you can pick up a growler, a 6-pack, a 12-pack, 20% of all of their profits on that day will benefit PNHP's internship program. And just to note, the owner of that brewery is a supporter of single payer, and they're very happy to have us back this year. So if anybody has any questions, I can put more info in the chat, but everyone is welcome to join us this Sunday at East Lake Craft Brewery. So thanks, Ann.
Yeah. Let me do, then I can turn these slides off, I think. And we have just a few minutes left, and if anybody wants a last minute question, feel free. I just will call your attention to all of our social media sites. We have Healthcare for All Minnesota is on Facebook, Instagram, Twitter, and LinkedIn. Let's see, not real active on LinkedIn yet, but I'm very active on Facebook. There's some wonderful posts. Please go in there periodically, you know, make it a habit to go in and take a look and see what's new and share. That's a big part of organizing. That's what we can all do, just in stepping up to our computers. See the calendar at HCA-MN for meetings and announcements. The Friday, May 20th, again at 5:30 p.m. is the fundraiser. And then we are tabling again this year at the Twin Cities Pride Festival at June 25th and 26th, partnering with PNHP Minnesota, yay. And we will need quite a few volunteers. It is a great opportunity. It's a fun event. It's a great opportunity to talk to a lot of people. I think we talked to over 560 people last year in 2 days. So it takes 5 or 6 of us at the table at a time. I believe we did 4-hour shifts. Please step up and volunteer. It's a great experience. This is at Loring Park in Minneapolis. You can contact me. I've got my contact information in the last slide. You can also write to info@hca-mn.org and let us know that you're available and what shift you would prefer, morning or afternoon. We do plan to table at Farm Fest in Redwood Falls in August. I think it's the 2nd through the 4th of August. That's a little bit more of a commitment unless you happen to be in that part of the state. People from our Hcam Mankato chapter are going to be helping us out with covering that. That's going to be an interesting event in, I guess, in rural Minnesota. And then, drum roll, please, we are at the state fair this year. We applied and we have space at the state fair. And I have to tell you, I am blown away. It was actually Jen and Dr. Crossen from PAT who brought it up last year. And I said, no way, that'll never work. It's too expensive, a little bit short on time to get it organized. And lo and behold, we started a little earlier this year. We inquired and it's doable financially. And the big challenge is going to be volunteers. We have to staff a table for 12 days from 9 a.m. to 8 p.m. in the evening. We will need a lot of volunteers. Again, it's a great opportunity. I encourage everybody to who can to volunteer. We will not leave you alone. We will have you partnered with people who can answer questions, and we'll have resources, of course, available. But I think this is amazing. This is an opportunity to interface with people we would never have the capacity to touch throughout the state of Minnesota. And as we build, toward a campaign for a bill here in Minnesota, it's an election year, so it's a great time to be at the fair. Have I made my case? Get some volunteers. All right. August 25th through September 5th. This is not the first time you'll hear about this from us. And there's my contact information, and then I will stop sharing in case anybody has any last minute questions, thoughts, comments.
I would like to share just one thing quickly before we go. A lot of you have been with us for previous events where we have talked about the ACO REACH program, and that is to privatize Medicare. We're vehemently against it. And if you would like to join us, and PNHP National, they have an event on May 23rd. It is called Turning Up the Heat on ACO REACH. It is a national campaign, and on the 23rd is the first day of the official campaign. We will be joined by Katie Porter, Pramila Jayapal will be there speaking with us and encouraging everyone, letting us know how we can take a stand against the privatization of Medicare. Because if Medicare is privatized, we're done. So I'm going to put in the chat right now where you can go to register to sign up. It is at noon on the 23rd. It's going to be an hour short commitment, and we really hope you can all be there. So thanks so much.
Thank you, Jen. How did I forget that? I'll put it on the slide too. So when they get sent out, people will have the information on the slide. Thank you. Oh. Plus we have a handout, a one-page handout, kind of a handy look at the sorry downhill slide towards privatizing and monetizing Medicare.
And we have a couple questions. Can we go ahead and work on those? Thanks. Sharon. Sharon, you need to unmute yourself. There you go.
Okay. All right. Since now we're just talking about the DCEs and ACO REACH, and some of us have already received our letters from Park Nicollet, M Health, and Health Partners, I believe. Anyway, we are going down to the state conventions, the Republican and the Democrat convention. The Republicans are the 14th of May. So, well, they also have some time, I guess, on Friday. I only have Saturday on my schedule, but if anyone would like to go down, we already have a flyer. I could show you what the flyer looks like. But we'll probably also make posters that we can stick in the ground because they won't let you inside the hall. At least that's what I last read. So if anyone wants to help, I don't know if most of you have my email, but if not, just ask Ann Jones. She has it. Linda has it. Don has it. Elizabeth has it. Anyway, so if you want to help do that, because we're supposed to be a nonpartisan party, we got to start working the Republicans.
Thanks, Karen.
What is the date of the Republican?
It's
Party
the 14th. Ours is on the 21st.
Oh, it's this weekend. We still have congressional district conventions this weekend, I think. Yeah. And where is the Republican convention?
It's also in Rochester, the same place. Yeah.
Okay.
I have one other person that's coming with me tomorrow, but I don't know if it's going to be like years ago, but there's thousands of people that usually come.
Thanks, Sharon, for letting us know. I'm
Okay.
gonna let Dave speak now.
Yeah, I just wanted to bring up, we're talking about the ACO reach and the privatization of Medicare, that we should all be calling our members of Congress and ask them why they signed on to a letter again this year, which they have done in the past also, to compliment how great Medicare Advantage is, which of course is our present privatized Medicare. And they just gush all over it. It was obviously an industry written letter, and every member of our congressional delegation signed it again. And so I've called Dean Phillips' office and said, what the heck is going on? Why are you complimenting this horrible, horrible product that people don't even know what they're getting into when they sign on to it? So I put the letter in the chat, and you can just copy and paste that, or just copy it and put it in Google and it'll pop up on your desktop. And keep that letter handy. And I just went through and I circled Ilhan Omar, I circled Betty McCollum, Dean Phillips, and all the Republicans are in there, and Angie Craig. So just wanted to bring that to your attention.
They
Thanks,
cite
Dave.
the benefits of Medicare Advantage, and it reads like they are all really captured by the notion that these managed care strategies have some magic power to save money, even though they have never, ever saved any money or really improved any quality of care. And they're acting like the insurance companies are magically able to deliver something that the healthcare system can't for some reason. They just really are kind of brainwashed, and we've got to just get them unstuck from the notion that any of this has anything to do with insurance. This should be delivered, whether it's telehealth or care coordination or managing chronic disease or long-term care or home care. All of those are care delivery measures, and they belong with the healthcare system, and they can be covered through by just paying the bill the way traditional Medicare was set up to do. It's
And we
going
have
to take
another
a lot of work.
question. Bob?
Hi, Bob.
Hi, Dave, that link that you put in the chat is a link to the downloaded file on your computer, not the link to be downloaded.
Sure. Dave, maybe you can email me the file and I'll put it in our follow-up email to everyone who attended.
Okay. We'll send
Thanks
out
for letting us know that, Bob.
we'll send out the summary for the description of the steps that we're in. The privatizing Medicare literally will destroy Medicare as we know it by the end of this decade, unless we push to stop it. PNHP is taking the lead, that's turning up the heat on an ACO REACH, which is just a rebranded direct contracting entities payment model. So I'll put the info on the slide for that.
Great. Well, seeing no questions, should we go ahead and conclude our meeting? Thank you so much, everyone, for attending. Again, there will be a follow-up email that I will send out probably early next week with the slides, the recording, and the resources that were presented in the chat. If you have any questions in the meantime, do not hesitate to reach out to us at Healthcare for All Minnesota. Thank you.
Our chair